be the last of the voices of the community.
I hope not.
No, for this last, let me finish. And we're working on a schedule for next semester, so take it away.
All right. Well, I also have a very informal introduction. I think Kathy's passion for hospice work and for HIV work will come through in her talk, but we were just talking, and she's been doing this since 1986. Was your first patient?
Yeah.
Before that. So she's a phenomenal storyteller. I had the wonderful opportunity to sit down with her and listen to some of her stories, and I think she's the perfect person to honor World AIDS Day this week, and I hope you all enjoy it. So thank you for coming.
Oh, thanks for inviting me. And I have a hall monitor in Julie Applegate, so just in case I get sort of horribly off track, which it really can happen. Thank you. This is really exciting for me. I love to talk. I know it's a disease on some level, I think. And I actually have been volunteering in hospice for over 30 years. And part of that has been patient care and advocacy and education. I've been to Russia, Poland, South Africa, and Tanzania with the National Hospice and Palliative Care as a hospice representative and study things. If I don't read this part, I will go so off the rails. That's why I'm doing it. It's a little to help me get started, to get focused here. And I started, the first time I went to Africa, I like to call myself an oblivious tourist. We were just there for a safari, and I had no clue what was going on, and that was in 1998. And then in 2000, I went back. I was going on a safari, but I also had the opportunity to take supplies through a friend to the Soweto Township Hospice, and that Soweto is Nelson Mandela's home township. That's how I let people know. And so I became a little bit more educated. I got a tour. The hospice was, it's now they have a building, but back then it was, you know, the containers they put on ships. They were about 5 containers put together, and that was the inpatient unit. And so as you can tell, I'm a talker. I love stories. I like to hear them as well as tell them. So anybody's, you know, when we get through with the film clip, then I'd love to hear yours as well. I did this story mostly because, okay, forget this. This is why I did it. I did it because as a tourist on airplanes, I would listen to people, mostly Americans, who are all going over, they wanted to convert South Africans to Christianity. Missed that ticket. They're about 98% South Africans are Christians, so that boat, I think, has already sailed. And the other thing was that the South Africans weren't doing anything about HIV, and that all they wanted was money from us. And so I thought, no, that's not going to work for me. So I talked a group of women, 5 women, to come with me. You'll see them, and to really tell stories, because what I saw with the hospice care in South Africa was its flexibility. We have sort of a 6-month prognosis or less for hospice care. You all know, you know, interdisciplinary team. Okay, good. You're all smart people. But they were taking, my friend who runs a orphanage was taking kids that were dropped off and just keeping them if they were ready to helping them get nutritionally balanced, getting them ARVs, and getting them adopted if that was possible. So a lot of really creative work. So now I'm going to show you this what I think is a wonderful 10-minute piece. I do want to just give a quick pitch. Janet Parrott, who's in your film department, is the director. Barbie Tootle, who's a speechwriter and alum, and a lot of people know her, is the script writer. We had Ed Blickblau, who was one of the editors, who was a Columbusite. All of the funding, every bit of the production was done right here. So don't ever tell me you can't do a project you think you should be doing, okay? So anyway, and watch out, because all of a sudden my head starts to spin. Anyway, this is a 10-minute part of a 40-minute film, and we did that because when we took the film back, the South Africans said, you know, this is great and we can do this, but we'd like to have a piece we can use in situations like this. So I don't have to press any buttons, do I? No, really, you don't want that. And my iPad is completely dysfunctional and I don't know why.
Even in the developed world, we don't know what lies ahead of us. None of us ever dreamed of AIDS. We never thought we would need to provide hospice services the way we are doing now. And we don't know what lies ahead. There might be some other major disaster where even in a developed country they can take the principles of what is being done in Africa and apply it there as well.
We provide palliative care where now we look at the person in totality and we try to give the best quality until the person dies. We look at the physical aspect, the social aspect, the psychological and the spiritual aspect of the person. We've got 5 home care sisters. So the sister who's responsible for that area will be the one going to visit to go and do an assessment. With hospice, we function as a multidisciplinary team. We've got the nursing sisters, we've got 41 community care workers, we've got the doctor, we've got the social workers, so that it is a holistic care which is provided.
We try to involve everybody so that when we finish, we know exactly what is the global problem of the patient. If he's very sick, we need to attend to it. If there are social problems, we need to either the field sister to go there or the social worker or the care workers in the field to visit the place.
Because of the extent of the problem, we don't deal with the terminally ill only. We deal with the whole spectrum of HIV/AIDS. If a person has just been diagnosed, the person does come to us for counseling because it can be traumatic. You know, it's no longer caring for the terminally ill. We are just caring for those with incurable diseases and taking the whole range as much as we can.
You have to think of hospice as like a net. It can be pulled very tight underneath families and patients when they need it, and then loosened when they don't.
The sisters cannot cope with the big loads that they have. That's why now we have the community care workers.
After my 3 brothers passed away, so like the people who came, like the people who were coming, helping us. So like I didn't have anything to thank them. So I also decided to come here, train and help others as they were helping us.
See you tomorrow again.
We've got community care workers that are assisting the nursing sisters. We provide training so that they can be empowered and be able to look after sick people at home.
Within South Africa, we have 11 official languages which represent the main cultural groups. But in fact, we have more than 60 different tribes. You can't just come from one type of culture and walk into these communities and expect people to tell you everything and to understand what's going on. We need our community workers. They're amazing people.
We've got caregivers in each community and they can connect with the patients because they understand the culture. We put the name forward to the patients and they can say yes, they want to work with this person and they know which persons they can trust.
Helping the community is one of the most important things because without us, there are without us, actually, it's going to be difficult for a lot of people.
As a care worker, I have to wash them, feed them, do the referral to the sister, to the social worker.
Along the way, I've gained passion to work with patients, because a lot of people need help.
I love them even more than my family, because I work with them daily.
There are patients who come to hospice for whatever their needs. So they visit hospice regularly. For those who are on antiretrovirals, they come for blood tests to see at what level is their CD4 cell count and viral load, how are they progressing, and then for their treatment. We also go out to visit those who are ill at home. And then those who are still up and about without complaints gather in a support group.
If we consider that 5.2 million people are positive in South Africa, and you kind of think, well, how on earth are we going to care for them all? It seems overwhelming. But if you go out and you help and meet and assist one person at a time, it really does become manageable.
I was called to this area called Musong, a valley of pain and suffering, where miners who went back and were infected their wives with HIV/AIDS, and they died, left many other people infected. They have about 95 patients and about 125 orphans to be cared for.
It's an old clinic where they started in the township many years ago, and then they used it as an employment office, and now they are using it as a hospice. Yeah, anyway, we have to see the way forward. What are we going to do with all the orphans, and are they accommodated well, and are they having the right treatment and care? And as you see, the grandmothers are so old. She's 1 year old, mother died also as well. Yeah, just look at this. I say, Mama. The clothes I get from a lady from Cape Town who worked in Canada. She's an artist. And she, from all the proceeds of her artwork, she buys the things from Ackermans and sends it to me. So these three have lost their mother. Sister, she's the household. She's the household. Their mother's going to be buried on Saturday.
I also do the care in a supervisory capacity, because hands-on caregiving is something very special. It makes the family feel happy and contented and comfortable.
So she's on ARV, and she's doing well on it, isn't it?
So this is important to have this kind of supervision and to see where the caregivers are doing and to help them and support them as well.
As hospice, we have started doing quite a few programs that are not really the core business of hospice. One of them is our Mapetla daycare program.
The daycare facility at Mapetla, we've got 2 classrooms that we are using in an unused school. So one classroom is used as a daycare for adults, and the other classroom is used for daycare for children of adult patients. Some of them have lost their parents, so it's orphans and vulnerable children that come to our daycare.
Last year, 22% of those little ones were infected by HIV/AIDS. We have taken it upon ourselves, with permission of course, to ensure that all the children go for testing, and so that we know what we're contending with. So that is one of the programs. Another is feeding schemes. We will make up food parcels and ensure that our patients or the children of the patients are fed.
We are happy that the government has started the rollout of antiretrovirals. But the problem is, what are the people eating when they take those antiretrovirals? You find that the person doesn't have money, doesn't have food, the person becomes depressed. So now how is the physical state of that person going to improve? You've got plus minus 500 patients. The food parcels that we have are only 60. So the home care sisters and the social workers are going to prioritize and give those that are very, very destitute their food parcels. But you'll find that almost everyone needs that food parcel.
It's a matter of hospice adapting to the needs of the community that they serve. And I think that's what every hospice around the world will do. I really think that what is happening in the hospices in South Africa and in other parts of Africa like Uganda can be models for other parts of the world.
Hospice to me is not a building, it's a philosophy of life. It's not prolonging life, it is also not shortening life, but it is giving the person the support and care and love until he dies.
By the way, the singing, that's a high school choir. And most groups that we visited in South Africa, when they start a meeting, they sing first. Think about how much better your classes would be if you did that. Maybe. You know, some of these statistics are now probably not relevant, because things certainly have changed in the last 4 or 5 years. But I do think that their tenacity in the face of unbelievably difficult circumstances still rings true. I mean, I've seen, I just feel so strongly that this is a great model. If it were up to me, this would be the way in which all healthcare would work. So that when you're born until you die, you have teams of people. You don't just have a doctor, you don't just have a pediatrician, you have the psychosocial spirit, and those people know you, or your child, or your family. And yeah, but you know, I haven't been able to get that passed in the legislature yet, but you never know. I'm trying to think. Joan Marsden, we call her the Pink Lady, runs a hospice in Bloemfontein. When I first met her in 2000, she had about 25 kids in a small house there, Sunflower House, and she had about 70 patients out in the townships. They're now managing 700 children and checking up on them and keeping records. And those children are not all HIV positive. They may just be in a lot of them have some other physical, some other disease, but she also, they're a presence in the community, and it's incredible. And Sunflower House has 35, well, I was just there in May and they had 35 children. And I'm on a roll with the story now. So I don't know if you all know about the Harmony Project, but the Harmony Project is a community choir. There are about 250 members, but you can't sing in it unless you're willing to do community service. And the director is David Brown, and they just had a sold-out concert at the Ohio Theater last night. One of his adjuncts is that he has created a choir at the Ohio Reformatory for Women, and it's their Tapestry, which is their drug and alcohol program. So David and I cooked up this thing where when I was in Bloemfontein, we Skyped the choir, his Tapestry choir, in to sing to the children of Sunflower House. Now they do it once a month, and the women are now knitting, because they asked me, they said, well, what can we do? You know, we can't collect money or whatever. I said, well, can y'all knit? And they said, yeah, a lot of us can. I said, fine, knit socks. So when Joan came for a conference here, she went out to the prison and they gave her 35 pairs of socks and finger puppets, which they've been using when they Skype. And John said, well, this is really great. I have 750 children out in the community. So they stood up without any prompting, and they are now in the process of knitting 700 pairs of socks for these people. And we found it to be, and the tapestry people have found this to be an incredible therapeutic connection. So here's another one. Come on, people, somebody's going to have to, good.
So I have a question.
Good.
The film in context in terms of when it was made and...
The women went in 2005 and it was finished, these things take time, funding and everything else, and it was finished in 2009. That's why, I always like to say, these are numbers, but don't. And there are some things out there that the numbers may not be correct anyway. But when I was, let's see, what am I going to tell you guys? Well, here's one. When I was in Russia in '97. The Soviet Union had collapsed. They had very little morphine because the government couldn't decide where they were going to get it, and it was a big mess, and they were worried about drug wars. So we went to this hospital, and this crazy Russian doctor with hair out the ear comes running in, and he's got a handful of dresses. And he comes in and he puts down a mirror. Okay. Then he comes back in, and these two guys carry this thing, long pole like this, with pieces of what turned out to be bell metal in different shapes and sizes. And he said, well, we have pain management problems here. We can't get the drugs we need. He said, so we do, the costumes are designed so the patient can hold it up, look in the mirror, and create well, he called it folk tale, but a fantasy. And he said, we find that it distracts them from their pain. But the best one, he starts banging on these bells, and they, when you sit close to them, they vibrate, obviously. He said, we think pain vibrates through the body the way sound vibrates through the air. So as the pain lessens, as the sound slows down, the vibrations slow down, so does the pain. And I thought, right, it's amazing. It works. I watched it, it's amazing. So it's where you look. And I so passionately believe that the third world has tremendous amount to teach us. We just have to listen. I mean, the amount of creativity, those community care workers are trained to at least, if not, in my opinion, from what I've seen in the manuals I've read, a better level of training than a home care worker is here at home. So, and what they do is, if they can pay them, they do. But everybody, volunteers and professionals, all trained to the same level. So if I'm a volunteer and they've got money, they pay me. If they don't, they give me a little stipend, but they can't pay me. And as Joan said, they're out in the community, they speak the language, they understand the culture, so you don't go traipsing in. I'm sure some of you have had that where you walk in, you're pretty sure you know what's going on, and then you realize you have no idea, no clue at all. Anybody have any questions? I'm going to keep rolling here. I don't, until you all either leave, fall asleep, or start throwing things. Those are all possibilities. But I'll tell you, filming is an interesting thing. Everybody thinks they want to be a filmmaker. Think long and hard before you do it. It's very difficult. What we found was when we went the first time, we took a sound person and 2 camera people. It was a nightmare. Most of what you see was filmed on the second trip, in which I held the mic, Janet did all the logistics, and we had 1 camera, because then we could move in and let people be more comfortable, talk about, culture clash, especially out in the rural communities. They were like, what is this? We also, that whole disclosure thing, we got that because in the rural communities, we didn't show it. we weren't allowed to, they said, we'll talk to you and we'll show you our support groups, but you can't show the film here. So we didn't. We showed it to the professional, Sister Kathy and the group, but we didn't show it into the community at all. Only the people that have been filmed were invited to go. Because stigma is stigma. A little while ago, Courtney, we were talking about this earlier, Courtney wrote me and said, wow, one of the things I'd like to know is what was the hospice response in Columbus in early HIV? And I went, well, let me just tell you that I'm an aging suburban housewife, community activist and volunteer. I don't really, in my experience with the hospice that I was working with, not a whole lot. But I think that's because the community was taking care of itself to some degree. But my first AIDS patient, and we had to go through all the protocols, was because wonderful Warren Wheeler, who was a terrific doctor who's now out in Las Vegas, but not as a showgirl, he's still a hospice doctor. Sorry, clear that up. He just came barging in the door. This is over at that time, the newly built Kobacker House, which was a 9-bed inpatient unit. Now they have a 24-bed huge unit. And he comes bursting in and he said, Kobacker, you're not doing anything. Put on the gloves, put on a mask. We're going to go in and talk to our first inpatient patient who had AIDS and tuberculosis and was in tough shape. And his family had just sort of dumped him on the doorstep. And we just held his hand and took care of him. And I had to go home and explain to my family that they were not going to get AIDS from me taking care of this nice man. So that's pretty much my story. In terms of that sort of thing. So I think now that wouldn't happen. We did a vigil for a young man, again, family just abandoned him. So the hospice said, we'll be his family. So we organized people by the time they dropped him, he was almost literally, he was delirious and so in and out of consciousness. So I sat from 3 or 12 to 5 because that's when I could do it in the morning and just held his hand. And I think I would say we've come a long way from there. But we also, as Oprah, I can't believe I'm quoting her. Oprah says, why did she do her school in South Africa? Because it's a hell of a lot better. And why didn't she do one for poor kids here? And she said, because it's a hell of a lot easier to be, it's never easy to be poor, I don't think. But the challenges in a place like South Africa, or parts of South Africa, are, those huts, those tin shacks you saw are no joke. They're there, they're everywhere. And so, it's a first world country and a third world country. So it has all of that tension, and it's a new democracy. It's only, 18 years old, I think. So, yeah.
So just to add to your Columbus AIDS connection in terms of what was here.
Please.
So I'd have to put in a plug for those who are in the health department, because I worked at an AIDS project in 89 and 90 for treatment.
Yeah.
And we did home care.
Yeah.
It came out of the Columbus Health Department. The Columbus Health Department was the one that was out
That's what I would have thought.
Out in the homes. And they did a lot of...
Did they do, because the first hospice in Columbus was at the health department.
That's right.
And then, I don't know exactly why, but they ultimately stopped doing it, I think. Well, perhaps because now we have quite a few. But yeah, so they were doing the home care. So they were doing hospice care, right? They weren't calling it that.
Right. And the issues at that point was the referrals would be very late, primarily because individuals were trying to not admit that they needed that much assistance in the home.
Yeah.
But it's just a sort of take on what was happening in Columbus.
Absolutely. And, I was in suburbia, you know.
It was the health, I mean, as usual, it's the health department that stepped up.
Yeah, absolutely, absolutely, and hugely important that they do. And, go ahead.
Can I ask, when I started working in HIV, it was in 2000 at the Ohio AIDS Coalition, and the Kobacker House was one of the first things I learned about as a community resource that provided hospice care. And you're referencing being a suburban housewife and all those things. I've always been curious, I've known you for a while, but I've never actually had the opportunity to ask you, what is it, like, with all the stigma that was happening in the 80s and 90s and lack of treatment and fear, what was it that made you comfortable, or the Kobacker House comfortable, to walk that path at that time and you know, be different than all of the other places that were too afraid to serve people living with HIV?
Well, one was Warren Wheeler. He was a leader in the gay community as well as one of the most highly respected MD Anderson trained oncologists in the city, and he just said, I'm not having this. And for me, you know, I don't know what it is. I think it's that old-fashioned bleeding heart liberal stuff that I just can't. I can't leave it. I can't leave it alone. And I think that, you know, we're still leaving some of it alone, and we can't do that. And and for me, the end of life care, I helped take care of a friend of mine who there was no hospice where she was. And I think that, you know, we have late referral problems, and you know, we can do it if you bring us, and by we I mean the hospice community. I don't represent any particular hospice. I don't volunteer for any particular hospice at the moment. All I would tell you is come to me if you have a bad experience and haven't helped them. Anywhere in the city. If you have a bad experience or somebody you care about does, you call me, and we'll make sure that we make sure that that doesn't happen again. Having said that, I think I want people to come, to not be afraid, to come, to understand that, you know, palliative care for me is hospice care up the river. But and that's, you can take all sorts of curative treatment, but you can have symptom management, and you can have a team paying attention to you. And that's what hospice does. We pay attention to you, and we pay attention to you at the end of your life. It's not an easy conversation, but it is an important one. And it is shameful to me in a way that it took, you know, hospice as long as it did for some hospices to respond to that, to the HIV. One of the women on the trip, the one who was writing, that's Pat Gibbons. She runs Beacon Place in Greensboro, and that was exclusively a hospice, AIDS hospice for years, and with antiretrovirals, they moved into support, and now it's an inpatient unit for whomever needs it. And everybody in this room, young people, you're going to be careful out there, right? Every day, right? Because I'm not your mama, but I'm not afraid to yell at you. Because, yeah. But anyway, yeah, you can't. And you all have something. If you haven't found it yet, you will. The nice professor in the back room cares about young children and their nutrition. And you can tell by the way she talks about it that she's just not having it. Just not having it. So find something you're just not having and do something about it, I think. You know, and all of these people, I'm picking on guys, but you have to admit there are an awful lot of women in this film. You know, it's amazing how much work they do, how much they care about it, and how good they are at what they do. And Joan, for instance, the pink lady, started Sunflower House and said, well, that's not enough. Children are not getting proper pain management. So she started talking about that and founded the International Children's Palliative Care Network. They had their first international conference in Mumbai, India, and they will have another one if anybody has an interest in Argentina in May of 16. So, yeah. So just you don't even really have to get angry. Well, sometimes it helps. You just have to kind of really get out there. And all of these women, the doctor who was talking is one of the world's experts on palliative care. She gave the first palliative keynote at the World AIDS Conference in Vienna several years ago. She is a South African doctor. They didn't ask somebody from here. They didn't ask somebody from Europe. They asked her. And she runs the African Palliative Care Network, which is an astonishing, it's the South African national network, and she's astonishing. And she's actually a lot nicer than I am. She's pretty cool. Anybody have any questions? Yeah.
I'm curious in your experience if you found that among cultures, different philosophies of end-of-life and mortality have affected how they do hospice care, palliative care. For instance, I feel like a lot of times in America, we're very interested in prolonging life and doing anything that's possible and not really listening to the patient as much and seeing how they want their end-of-life to go.
Oh, that's a great question. I think that what I observed was that this whole business of the 11 official languages. So you get that home care worker. It's smart. You have the home care worker who's from the hood. They walk so that they don't have to, so that they don't have as many cars, so that it has that element as well. And you get that person to be the interpreter. We wouldn't have been able to go into the homes that we did had it not been, started with the home care worker and the nurse and the reputation of the hospice. And it's flexible. And because they don't have reimbursement issues the same way we do, they don't, so they can be sort of more flexible about it. And some of the tribes, you don't talk about it, some you do. It's just kind of depends. When you go in South Africa to a major sort of government building, 11 official languages, they're not kidding. Another thing that they do that I think is really amazing is, I don't know, maybe 4 years ago, maybe 5. I like to fake it because I'm old. I was on this campus and having dinner with the ambassador to South Africa, the South African ambassador to the United States. And on the other end of this campus, on the same day, Wangari Maathai, the late Kenyan Nobel laureate who was getting into planting trees and conservation and getting Africans to be aware of that. So at the end, we were talking about it, and the South African ambassador's assistant said, "Gee, I'd really like to go hear that." And I said, "Fine, I'll take you." So I did, and he was really excited about it. It was really interesting. We're driving back to the hotel, and he goes, "Kathy, where is your public information on HIV? Where are your billboards? Where I see nothing." And I said, "This is Ohio, we don't have sex." Which leads me then to my absolute favorite this is a billboard, right? And this is right in the middle of one of the busiest streets in Soweto. And they're in all communities. They have information, maybe not always billboards. It's huge. It's black, white lettering. Okay, so there's a set of magenta feet going this way, and another set going this way. Now we all know what's going on, right? Because we're not, we're visual. Think about it. Got it? Okay, good. And what does the billboard say? HIV loves sleeping around. Why do we not have that here? We should. And the South Africans have this sort of stuff. You can't go to a doctor's office. You can't without information being right out there. And this is beaded, and it was made by Soweto Township daycare patients. We don't do a whole lot of daycare in this country for hospice patients. Poland has the most amazing daycare setup I've ever seen, and they have a tremendous setup in Soweto brings people in. If they're on antiretrovirals, they can check them because they give them a little lunch, and then they do beadwork, so they have a craft they're developing. Some people make dolls and all sorts of things, and it's a way to check, it's a way to feed, it's a way to give a small skill. When I first started going to South Africa, or to Africa, into South Africa, and I would wear this pin, people ask me about it all the time. You know what's really sad? People don't ask anymore as much, which I find sort of, you know, it's still here. You can still get it. I mean, Julie had a fabulous panel on Monday at the Ohio AIDS conference, and with a 20-year-old young woman who will live the rest of her life on antiretrovirals, or she won't live. And the argument also is that her life may be shorter as a result. So, I don't know. My family says I like to lecture people, and it's probably true to some degree. I'm just trying to think of, do you have any other questions? If you get me rolling on a question, then usually I can, you know, fake it from there.
I wonder if some of the other quote-unquote alternative therapies for pain or something along those lines that we can learn from the third world that we haven't brought into this country, and maybe some ideas you might have of how we slap people around and say, hey, listen.
I just do it.
You just do it.
Yeah. Wear an obnoxious T-shirt and just do it. You know, you know, you have what they've done is, you know, the Sangomas, you know, the herbal doctors, some people call them witch doctors. What they found was that people would obviously, especially in low-income areas and tribal areas, would go to them. So what they figured out was that wasn't necessarily going to work, and you know, some herbal remedies would conflict and that sort of thing. So what they did was they began to bring Sangomas in, train them, and give them all of the HIV information. So it doesn't really answer your question in that sense, but they have, you know, they just use what they've got and however they can, because, you know, to say herbal things can conflict. And, you know, there was the old, you know, drink Drano and you'll be cured kind of thing. I never personally experienced the whole thing with raping children to cure AIDS. I mean, I heard it, but I never have any personal experience. So in terms of alternatives, high touch, low tech, they're really, really good at that. Part of it is because they have to, and part of it is because they believe it. I never saw anybody who wasn't. And we are, in theory, we're high touch, low tech, but I'm not sure that's always entirely in the same way that they are. I wish I could answer it more fully, but I really, you know, I can't, because I don't really know. I didn't see a whole lot of it. The only thing we saw was the beginning of the Sangomas becoming trained and becoming spokespeople for antiretrovirals and discouraging that whole business of, you know, the Drano cocktail or something. Yeah. Oh, come on. Somebody's got to ask me something. Can you ask me where I live?
This is more of a domestic question. I was just curious when you talked about, I assume you talked about the women in Marysville.
Like, yeah. Mm-hmm.
So are we doing any kind of work to see if the activities that you're having them engage in is doing anything to improve their quality of life, or in the long run after they're not incarcerated anymore? Could we get some information that maybe
this might be a really great project here.
A student or someone.
Hello, yeah, it would. Yeah, I can definitely. You give me your card or something, and absolutely, because what is interesting is their recidivism rate is within the Tapestry program, their drug and alcohol program, is very low. And you have the people who are in there who will be in that program and then go home, and you have the people who have done some significantly other bad things and will be there a while. And so I don't know what the recidivism rate is within that. I met a woman the other night at a volunteer dinner at ORW who has been incarcerated for 35 years. She makes the most extraordinary quilts I have ever seen in my entire life. But yeah, I mean, it's, I would love that. I would love to see that, because this is this is like a project that Julie's working on with orphanage and HIV positive kids in Honduras, and taking a friend of ours, another Courtney, we're going to take a group of these kids along with Julie down to their HIV positive, meeting HIV positive kids, and seeing how that goes. So I'm really big on, I'm not big on the outcome in the normal sense. I'm not hysterical about that stuff, but this is really interesting to me. And I think you should see these women with the kids. It's amazing, and they scream, and we're trying to get all of the requirements so that on the Harmony Project website, they can show you this great little video that they did of the kids screaming into their little thing in the sky. And it seems to be, they painted a wall. I brought them pictures of some of the kids. They painted a wall. It's the most beautiful thing you've ever seen. The sunflowers, and the pictures of the children are in the center of the sunflower. And and all of these projects. So it feels good. I want it to be good. So you guys like know math and statistics and stuff, right? Yeah, I think that would be wonderful. Would you guys be interested in something like that? Hey, a project, I love
It
it.
reminded me of I don't know if you saw in the dispatch last week, I think she was 5 when she started it, these are lonely socks, there's something.
Yes, I know the mother of that child.
Yeah.
Yeah, it's Ruth Milligan who does the TEDx. You all?
Yeah.
Yeah, that's really fun stuff. Yeah, isn't that the coolest thing? She takes the socks, that don't match, and matches them up, and yeah, it's exactly. And I know that that's just a good thing. It's just a good thing. And I think this tapestry thing is a really good thing, but it needs to be proven. And I don't exactly know it, but I think Comp Drug is is Comp Drug a 501? I don't know what their deal is. But they fund the tapestry thing. I don't know what their deal is, but and so the more we could prove it. They have an alumni association. So these women who go out will go into an alumni group. And they meet and they process. So that's part of it. That helps as well. Anything you can do.
So I think one of the purposes, I can't speak better of these opportunities to have people come in is to sensitize all of us to what we can be doing more in the community, either here or globally. So this is.
Yeah, it's great. And we were talking earlier about the fact that OSU is partnering in Ethiopia, and that's going to be amazing. That's going to be amazing. And you all will have to, put your noses in there and see what's going on, because there's lots to do. There's lots to learn. There's lots and lots to learn. And the trip over is awful. It's so long. And, I've also, not hospice related, but went to Liberia with American Jewish World Service. They're a really interesting group of people. They don't work in first world countries. So they don't work in Israel. They're not political in that sense at all. And they funded Lema Bowie, who is the Nobel laureate who got Charles Taylor kicked out of Liberia. It's an amazing story. If you don't know about her, look her up. She's incredible. And they were one of her first funders. And I don't know if they're in Ethiopia or not, but they would be interesting people, because what they do is they have Africans who sort of cover the continent in terms of the countries they're in. And then what they do is they find local people. So Rosalie, who was the one of the West African reps, found the people in Liberia and worked with them. And that Ebola thing is so tragic, because because they were just beginning to get on their feet. 1%, and we were there, 1% of the countries on the grid, you know, they're just trying to rebuild to get, but that's what happens because if you don't have the infrastructure, you can't fix it. Plus, by the way, anybody been to the CDC? Yeah, I went on a tour. It's amazing. You'll want to get jobs there. It's a very nice campus. Really. It's got a stream that runs through it. It's gorgeous. Wow. Pretty fancy. But they have a room that looks like a NASA launch site. Really does. It's got the thing. And on the wall, they flash all of the different things, HIV, Ebola, whatever is going on in the world, and they have it all color-coded, and these people sit in front of their computers. It's amazing. I don't know what the pay is, but it's really beautiful. And they got nice apartments across the street. Really, I'm not kidding. So what are you all going to do? All right, so you asked the question, what are you going to do with your degree?
My degree?
Yeah.
Well, I applied to med school and
excellent.
MD.
Good. All right, so if you're going to do that, one charge I have for you, and that is you cannot, in this day and age, I don't care what kind of doctor, you have to do a palliative hospice rotation. You just have to. Because whatever field you go into, you've got to be able to understand that conversation and see it sooner. Please, God, see it sooner. Because if you're in it to relieve suffering, and, you know, and palliative care can start the minute you start any kind of life, if you have a life-limiting illness, you can start palliative care right there, right then, to march along with you. Nobody, hardly anybody does that. So what kind of a doctor you want to be now that I've lived?
I don't know.
Don't know? Good. Well, all right. So perfect. So that rotation works right now. Okay, what about you?
Me?
Yeah.
MHA, I want to be some kind of administrative in a hospital system.
I spent most of this morning till 1 o'clock over at the hospital with my husband having a procedure. You sure you want to do that? Nice people, really nice people, but you sure? No, I'm teasing you. So what kind of a degree did you get with that?
Master's in healthcare administration.
Wow.
But I mean, people have taken other routes also.
What about you? You actually asked a question. Did you teach?
I am actually a hospital chaplain resident at Grant.
Cool.
Taking care of oncology and palliative care.
Wonderful. The rotation we did was at Grant.
That's fabulous.
Yeah.
I would like to advocate for more interdisciplinary teams.
You go, and you are so much more an important part of this than people realize. And you know, you got to meet my favorite chaplains, the two crazy Buddhist monks from New York. They are at Beth Israel, and they're the resident chaplain. They give you a card.
Yeah.
You'll love them. No, but really, this, you know, I know guys, science, math, all this kind of administration. This guy does really, really important work. Just kind of sensing what the flow is like. And, you know, it's crucial. All right, okay. What about you?
I'm doing my master's in health behavioral promotion and applying for a PhD in epidemiology program.
What is
Epidemiology.
Okay, so
Chronic disease and disability, quality of life.
Unbelievable. That's great. Wow. There's a nice kid from Columbus who has he's probably not exactly, never mind. Anyway, that's very cool. So, PhD, my son's girlfriend is just working on her thesis. She didn't want to do, no. Don't ask her when she's finishing. No, oh man. But there's a lot of swearing involved. What about you? You were here first, we should talk to you.
So I'm applying for School of Public Health right now, and probably become an epidemiologist as well.
Okay. See, when I think of epidemiologists, I go to the CDC with the white walls and the mosquitoes.
Yeah, that's like my dream job right now.
Okay, explain this to me. So they have the vapor lock, right? You know, because of the mosquitoes that they're testing. And you look up, you're in the vapor lock, and you're about to go in. They have a $25 bug zapper. This was not encouraging. Not at all. So, yeah, yeah, you want to work there. It's amazing. It's absolutely incredible. Yeah. Well, good luck. So when do you find out about your application for your?
Probably like that race.
God, you're all smart. It's disgusting.
Oh, so I have my MPH from University of Cincinnati, but
Wow.
I work at Columbus Public Health with
Oh,
Courtney
cool.
and Julie.
Oh, great.
Yeah.
Great. What do you do?
A Ryan White linkage to care coordinator. So I work with people that are newly diagnosed with
I
HIV.
just talked to a nice person from Cleveland, I think, was at my table the other day. So it's fascinating. What about you?
Oh, me? I'm a staff member. I'm a staff member. My school days are behind me, so staff member here in the College of Public Health.
Cool.
Yeah.
Gotta do something about those seats out there. This kid
The
in.
bench.
Really? Seriously, people? Yeah, this kid and I were trying to figure out, we tried to find a place that you could sit in those things and actually be comfortable. I think we should find the person who designed them and make him sit there for the day. They are just ridiculous. I mean, the building is fabulous. Oh, it's gotta go. Really, something, anything, like a back on them, just a back would help. Yep.
I'm a clinical research coordinator in James Cancer Research here.
Cool.
But actually I worked in 97, 98, 99 in HIV department in Romania.
Wow.
I work with kids infected with HIV with mothers negative.
What?
Yes.
How did that happen?
We had a epidemic. I'm very emotional if I talk about this.
I didn't mean to put you on the spot, but.
Yeah, so, you know, we were a comics country.
Yep.
And there weren't syringe for clinical use. So the nurses, well, use the same syringe for the same kids for vaccination and stuff like that. So there are cities with, you know, in our country you put a sign, a black sign when you have somebody died in your house. So there are not city, villages with every single house with a black sign. And that is for kids. Yeah. I have a lot of stories and I want to meet with you.
Absolutely, anytime you want to. Yeah, it's amazing, isn't it?
Yeah.
You know, we get so, well, you know, my understanding is that China has, they don't talk about it, they have a tremendous problem because they were doing this process of taking blood from farmers, you know, and the old Red Cross truck, as it were, but for some reason, re-injecting some blood or something, I don't know. I mean, it's
No, I don't think, well, there were two things. One, it was that the blood wasn't tested for
right, okay.
transfusion.
Yeah.
It wasn't screened. And second, I think all those kids, they were healthy till they were diagnosed. So they didn't receive any transfusion. So the theory is that they got it from the vaccination. So it wasn't, so the nurses didn't take blood and inject it. They just used the same needle, the same syringe.
Right.
That was the problem. Yeah. And I worked there and a lot of parents were angry on us, on the medical staff.
Sure.
Because we were responsible for that.
Yeah.
Yeah. And we had it was a very hard to build confidence and trust.
Yeah, no kidding. Yeah, exactly, and that's exactly, I mean, we've seen that in the Ebola problem in some cases, and the same thing with antiretrovirals, and truthfully, you know, it's not just if you don't have the money, it's, well, I mean, if you don't have food, if you don't have money, people would sell them. You know, and then not take them and all that sort of stuff. God, children.
But it's the most amazing
Yeah, and now
part
you're
of
doing,
my life.
yeah, and now you're doing cancer research?
Yeah, well, I did a mistake, I married.
How long have you been married?
14 years and then divorced for 1 year.
Yeah. No,
And
but cancer
he
research.
came here, so I came with him.
Yeah.
But it was very hard for me to stop
Yeah.
doing what I did.
Yeah.
And I'm still in touch with them. I'm friends with my patients.
Of course.
A lot of them were, some of them are alive because they are on therapy now.
Yeah.
And some of them, they were just infected by the time they
Yeah.
were diagnostic. One of the lady, for example, was diagnosed when her husband was diagnosed with with a syndrome.
Mhm.
He was in the last year when I met him, and he died after that. And of course, as you said, everybody knew in her village that
Yeah.
she had HIV. So she was completely isolated. She couldn't find jobs. She couldn't. She lost all her friends. So the only friends she had were us. You know. So we are still friends.
Oh, that's great. So she's
No.
okay though.
She had a terrible time. I think 10 years. She couldn't find jobs. She
Mhm.
basically.
Yeah.
She was homeless. Well, she had a house, her father's house, but she struggled a lot. But eventually, she was helped by the social workers.
God
She was
loves social
included-
workers.
Yeah, she was included
And chaplain.
in a group.
Yeah.
And she met somebody there. She remarried, and they start a business. She's very good.
Oh, that's
very well.
great.
She travels now.
It's good.
She doesn't care that whoever doesn't like her, she has HIV. She doesn't care because
You
it's
kind of
still a
have to get
problem
there, don't you?
in Romania. You know?
Yeah, exactly. I wonder, I'm gonna have to find out from Joan. I have to hook you up with Joan and her International Children's Palliative Network.
Okay.
Yeah, and please, could you just cure cancer while you're at it?
I'll try.
Good, because it seems to have done some other great work. We're running over, but I don't mean to discriminate against somebody I haven't nailed to the wall about what they do. They're in the back there, let's make it quick. What do you do? Yeah, you.
I'm a postdoctoral fellow here, actually. I'm a JD, I'm a lawyer. So,
That's okay, my kid's a JD.
but I'm doing my MPH too, so.
So are you a lawyer or just a JD?
I'm a lawyer.
Okay. No, because my son's a JD, but he's not a lawyer, and he makes that very clear, so I was just trying to.
Well, I'm licensed. I don't practice.
Right,
Because I'm
right.
doing research and writing here for Anti-Tobacco Center.
Good. Yeah, well, those of us that smoked are grateful that you're doing it now. Who thought, who knew? You guys got a nice building, we thought you were all a bunch of bimbos doing nothing, and clearly this is not the case. This is a busy group. Anything. One of the things besides talking that I love to do is connect people. I have cards, take them. If you think of something where I can be helpful, I'm happy to do that. And, this is really a treat. You guys are really impressive. You young people are going to do great things. And we need you badly. We really do. And I have to say that between these folks and my tour of the CDC, I got a whole new perspective for you all with public health. You're not just, number, not kidding. But this is, you're doing God's work, really. You really are. It's so important. And if we haven't figured that out in the last 10 years, I don't know. Thank you. It's great. I've had a great time. As I say, if Courtney doesn't give me the hook, I'll just keep talking.
Well,
Okay.
thank you.
Thank you. And then that about cards too, by the way. I have them, I'm happy to give